Welcome to the Anesthesia Academy. Today, we are taking a deep dive into the pharmacology that can truly make or break a case. We're going to explore the critical decisions you have to make every single day, from induction all the way through to emergence, and the drugs that help you navigate that journey safely. So, we're going to frame this like a clinical case. We'll start with that high-stakes moment of induction, move through the delicate balancing act of maintenance, and then tackle the critical final phase of emergence. And along the way, we'll hit the key autonomic agents and monitoring techniques that are your absolute safety net. All right, let's get started. Whether it's the most routine procedure or the most complex case you'll see all year, it all boils down to a precise second-by-second application of pharmacology. Mastering these drugs isn't just about passing exams, it is the absolute foundation of patient safety. So let's start with that first critical step, induction. Okay, our journey begins at one of the highest risk moments we face, securing the airway. And to do that effectively, we often need profound muscle relaxation. That brings us to the Neuromuscular Blocking Agents, or NMBAs. So what are NMBAs actually doing? Well, they're working right at the motor end plate, interfering with how acetylcholine normally triggers muscle contraction. But, and this is the key point, they do it in two fundamentally different ways, which splits them into two major classes, the depolarizing agents and the non-depolarizing agents. Now, check this out, because the core difference in their mechanism is fascinating. Succinylcholine is an agonist. It actually mimics acetylcholine, but it sticks around, causing this prolonged depolarization that leads to paralysis. Rocuronium, on the other hand, is a competitive antagonist. It just sits on the receptor, physically blocking acetylcholine from doing its job. This is exactly why succinylcholine is so fast, but it's also why rocuronium's block can be reversed, and it's why they look completely different when you use a nerve stimulator. And boom, this picture says it all. Look at the train of four for a depolarizing block. See how all four twitches are there, but they're just smaller? There's no fade. Now, compare that to the non-depolarizing block on the right. You see that progressive weakening? Twitch 4 is way weaker than Twitch 1. That fade is the absolute hallmark of a competitive block, and it's what we rely on to monitor the depth of that block. Okay, so the key takeaway here is that while succinylcholine is incredibly fast, and that's invaluable for a rapid sequence induction, it is not a benign drug. It comes with this whole list of serious risks. The big one is life-threatening hyperkalemia in patients with upregulated receptors. Think burns, spinal cord injuries. It's an absolute contraindication. It's also a massive trigger for malignant hyperthermia, so careful patient selection is completely non-negotiable. All right, the airway is secure. Now our focus shifts to the maintenance phase. We're constantly dealing with the hemodynamic swings from our anesthetic agents and the surgery itself. To keep things stable, we turn to a totally different class of drugs, the adrenergic agents. The pharmacology here is really a balancing act. We have agonists, our pressors that hit the accelerator on the sympathetic nervous system to treat hypotension. And then we have antagonists, our blockers that hit the brakes to manage hypertension and tachycardia. We're constantly tailoring our response, minute to minute, based on what the patient needs. So when we choose a pressor, it's all about the receptor profile. Let's say you have hypotension, but the heart rate is already high. A pure alpha-1 agonist, like phenylephrine, is a perfect choice. It's pure vasoconstriction. But if you need to support both blood pressure and heart rate, then ephedrine, with its mixed alpha and beta activity, makes more sense. Just remember with ephedrine, it works indirectly by releasing norepinephrine. And if you give dose after dose, you can deplete those stores and see tachyphylaxis, where it just stops working as well. And we see the same logic on the blocker side. Labetalol is a fantastic workhorse. It's got that mixed alpha and beta blockade, so it lowers blood pressure without that nasty reflex tachycardia. But it hangs around for a while. Now, for super rapid, precise control, especially for heart rate, esmolol is king. Its half-life is only about 9 minutes because it's broken down right in the plasma. That means you can turn it on and off almost like a light switch, perfect for managing those quick surgical stress responses. All right, surgery is wrapping up, and we are entering the emergence phase. Now, we face one of the most critical jobs in all of anesthesia, safely, completely, and reliably reversing that neuromuscular blockade so the patient can breathe effectively on their own. And this question is a big deal. Inadequate reversal is a major cause of post-op respiratory problems. The traditional way we've done this involves tipping the balance of power back in favor of our own neurotransmitters. So the classic approach is indirect. We use a drug like neostigmine, which is a cholinesterase inhibitor. Think about it. By blocking the enzyme that normally cleans up acetylcholine, we cause a massive flood of ACH right at the neuromuscular junction. This tidal wave of acetylcholine can then outcompete the rocuronium for those receptor sites, and voila, neuromuscular transmission is restored. But here's the catch. Increasing acetylcholine everywhere has consequences. We want its effect on the muscles, sure, but we don't want its muscarinic effects on the heart. That's why we must co-administer an anticholinergic. We pair neostigmine with glycopyrrolate because their onset times are really well matched, and that gives us a balanced effect that protects the patient from some really profound bradycardia. But in recent years, this whole model of competition has been turned on its head by a totally new way of thinking about reversal. Instead of fighting the blocker, what if we could just get rid of it? And this is Sugammadex. This drug is, frankly, a marvel of pharmacology. It's a modified cyclodextrin that acts like a molecular sponge, specifically designed to find, trap, and inactivate Rocuronium and Vecuronium. This allows for incredibly fast, incredibly reliable reversal of even deep blocks, with zero muscarinic side effects. It's a true game changer, especially in a can't intubate, can't ventilate scenario where reversing a deep Rocuronium block quickly can be life-saving. We just talked about using anticholinergics for reversal, but of course their utility doesn't stop there. Let's just take a closer look at these drugs, because they're critical tools for managing all sorts of autonomic reflexes during a case. So, which one do you pick? Well, it depends entirely on your goal. Atropine is the most potent at jacking up the heart rate, making it our go-to for vagal bradycardia. Scopolamine crosses into the brain really easily, so it's a great sedative, and it dries up secretions. But that also comes with the risk of central anticholinergic syndrome. And then there's glycopyrrolate. Because of its structure, it can't cross the blood-brain barrier at all, making it perfect when you just want those peripheral effects, like drying secretions, without any sedation. And this brings us to the final and maybe the single most important piece of this whole puzzle. None of this fancy pharmacology matters if we aren't measuring its effects. When it comes to neuromuscular blockade, you cannot manage what you do not measure. Objective, quantitative monitoring is absolutely non-negotiable for patient safety. The gold standard for monitoring is the train of 4, or TOF. We deliver 4 quick electrical pulses, and we watch the muscle's response. In this picture of a moderate block, you can see we only get 3 twitches back. The 4th one is gone. That means our TOF count is 3, and our TOF ratio, which compares the 4th twitch to the 1st, is 0. This gives us a clear objective number for the block's depth. I love this diagram because it shows the patient's entire journey. See, over on the left, we start with a deep block, maybe a TOHG count of 0 or 1. That's what we need for intubation. And as the case goes on, we move to the right through the moderate and shallow phases until we reach our final goal for emergence, acceptable recovery, where all 4 twitches are back and the fade is minimal. So what is our objective safety target? All of this monitoring, all this pharmacology, it all comes down to one number. And if you take nothing else away from this talk, remember this. A train of 4 ratio greater than 0.9. That is the minimum evidence-based standard for adequate recovery. Anything less than that is associated with weakness, airway problems, and pulmonary complications. It is our objective safety target, period. So in the end, mastering the pharmacology of induction, maintenance, and emergence is really only half the battle. That mastery has to be paired with vigilant quantitative monitoring. It's that combination, that synthesis of precise drug administration and objective data that forms the unshakable foundation of patient safety in modern anesthesia.